Hello, my name is Michelle Morand, and I'm co-founder of Cancer Treatment Options and Management, a worldwide personalized cancer research and advocacy service. And today I am speaking with Tom Turcat of OmiCure, and I'm just going to turn the floor over to you, Tom, to tell us a little bit about this exciting new test that you folks have developed and how it can help cancer patients. Of course, I've got some questions for you. But first of all, tell us, what is the OmiCure?
Well, first, Michelle, thank you very much for having me today. I'm very happy to talk about this. So OmiCure is, what we call a tumor profiling test, which means we are looking at the tumor molecular profile. It can be DNA, RNA, and from that, we are providing personalized data to oncologists to be able to choose the best treatment option for the patient. Okay. And what we are doing quite differently in OmiCure compared to other tumor profiling tests is we are looking at RNA expression.
RNA expression.
So RNA, as most people know about DNA, DNA is the code of any cells in the body. And every people has the same DNA for the cells of the eyes or the cells of the hand. And what makes the eye different from the hand is the RNA. Is the way RNA is the way only some genes are used by the cells to create a hand or to create an eye. And so what we are doing is we are looking. We are not looking at mutation on the DNA. We're just looking at which genes are used by the cells and by the tumor. And then we compare this usage and so the expression of the genes to a healthy, similar tissue. And so we get a list of all the genes which are what we call dysregulated. They can be overexpressed, or used too much, or they can be underexpressed. And from this list of dysregulated genes, we have developed an AI platform that match this dysregulated list of genes to a huge worldwide knowledge base of known drug-gene interactions. And so what we were trying to achieve is we're selecting drugs on their capacity to correct this dysregulation. And so, of course, it's more complex than that. And the AI calculate computer score depending on the gene triggered by each drug on the level of dysregulation. And then we provide a list of the 10 best drugs, but based on this dysregulation knowledge of the tumor, might be the best to correct this dysregulation.
Okay. Wow, that's a lot. That's exciting, but that's a lot. Let me just recap to make sure I understood. So that was interesting about the RNA. I appreciated that explanation because it can be difficult to understand the difference between the two. So I might need you to say that again. So the sure. RNA, it's kind of telling the body what to do, or what exactly does it?
In fact, we have, I think, something like, let's say, about more than 22,000 genes in the DNA for each cell. But all the genes are not used by the cells to create what it is. I mean, the cell of an eye makes some protein to make the color of the eyes, and the cell of the nail makes some other protein to make the nail. You see what I mean?
Okay.
And it's not the same genes that code the creation and the production of this protein. So it's not the same gene that are used.
Okay. And so, go ahead, sorry.
No, and so let's say, I don't know if this is just a hypothesis, but for the cells of an eye, maybe it's like 5,000 genes would be used, and for certain of the nail, would be some over 10,000 genes would be used. Wow. And so the RNA is just the expression, the genes which are used for each cell. So of course, when you got a tumor in your liver, or got a tumor in your lung, it's not the same genes that are used. And so we are able to compare this to normal genes that are used. And we can see that in some tumor, some genes are much more used than they should be. So we call it overexpressed, or they are underused, so compared to what they should be. So we call them underexpressed.
Okay.
And something important, just sorry to finish this, and we know, and on coming from the huge amount of publication in oncology, a lot of drugs, we know what effect they have on some genes. We know so that some drugs are increase the level of expression of some genes, and we know that other drugs will decrease the level of expression of other genes.
Okay, I think it's all coming clear to me now. So let me try again.
Yeah.
So your test looks at the RNA. It compares healthy tissue and cancerous tissue, and it looks to see which of the genes that are present are most present or most expressed in the tumor tissue versus the normal tissue.
It's not most expressed, it's more expressed, it's differently expressed.
Okay, differently. So it can be more or it can be less.
Yeah.
Thank you. Okay, so we get a normal tissue sample, and then we have a cancerous tumor sample, and then you compare those two to see which of those genes there's more of or less of than the normal tissue. Yeah, and then if I heard you right, there's this artificial intelligence AI platform that you put that information into for each patient to access. I can't imagine how many studies or how many thousands of pieces.
Millions.
Millions. Okay, millions of studies, millions of pieces of information to ultimately culminate in a short list of 10 treatment options. These are medical science, peer-reviewed, evidence-based treatment options that would be available for patients, oncologists to prescribe, that would directly address this issue of overexpression or underexpression of those genes.
Exactly.
Oh, wow.
Thank you for telling it so well.
My pleasure. I started out saying I'm excited to get to chat with you, but extra excited because this is, as you were saying, there's certainly benefits to understanding the DNA, which is a very common, increasingly common phenomenon in cancer care right now, is DNA testing, and something that we certainly utilize a lot with our patients. But being able to look at the other side of the expression, it's like a deeper look.
Yes, it really gives a complementary point of view on the tumor profile. In fact, DNA testing is quite widely used currently in all Western countries, and in fact, maybe it's used for almost 10 years now. And in fact, it seems that for many studies, it has demonstrated that we find really actionable data and find actionable treatments, sometimes between 20 and 40% of patients only. Because sometimes the mutation, we don't find any specific mutation, or sometimes we might find a mutation, but you don't know if this mutation is expressed or not in the tumor. So you might give a treatment for a given mutation, but maybe the mutation is not expressed, or you will give a treatment without any real purpose. So really, the using RNA enabling to be closer of the reality of the tumor, because in the functioning of the cells, you got DNA, and then DNA becomes RNA. It's only the genes which are expressed, and then from the RNA, the tumor will create and produce the protein that makes the cells being a cell.
So it's even so from what you just said, the OmiCure RNA test is a more precise assessment of what's going on. Did I hear that right or no? Than a tumor DNA test. Oh, you're muted somehow. Oh, there we go. Okay. Don't know what happened there. Go ahead.
So I'm can't sure I could say it's more precise, but it's more close from the reality.
Okay. All right. I'm gonna muse on those words there, but I appreciate you're trying to be as clear as you can. Okay, so let's go back a little bit to talk about how this test got initiated. I mean, it's, as you were saying, it hasn't been very long that tumor DNA has been a thing we can test for. Certainly when we started Cancer Treatment Options and Management 11 years ago, it was definitely not something that was
quite innovative at that time.
Yeah, it really was. And as you know, what you're saying right now, how our director of research, Alex, and his team got the information that you can now provide with so much more precision and ease, was we would get tumor DNA testing, and then they would spend about 30 hours researching all the bits and pieces and extra details. And then on top of that, Alex had to design a blood-based genetic test to assess for expression. So that was a lot of time and a lot of effort to try to get close to what you can now do with your test and your automated system of data gathering. So it's really exciting times. But tell us how this test came to be.
In fact, you know, OmiCure's is quite a young company. It has been created less than 2 years ago, but the technology, in fact, has been created in a sister company called RNA Pharma, and it was a very huge collaborative consortium 5 years ago, and they had this hypothesis to compare the selection of treatment either based on DNA or based on RNA. So we designed a clinical trial called Winter, and it was run through USA, Canada, Spain, France, and Israel. Mm-hmm. And they were testing patients from different kind of cancer and trying to compare the overall outcome. And the conclusion of the study was that using RNA, they were able to find a treatment for all patients using the RNA test. And in addition of that, the global additional survival rate was increased of 45%. So it was very late stage patient. It was over treated patient. So it's in a small clinical trial about more than 100 patients, but still it was a huge performance, and so it enabled us to have a publication in Nature Medicine magazine, which is, you know, the kind of the one of the most famous scientific publication.
Yes. Wow. So
and so just to finish, based on this publication and the result, we have created OmiCure to be able to continue to develop specifically just this test, and to be able to industrialize, to automate it, and to commercialize this test to patients.
That's exciting. And for those of you who want to look that up, the Winter trial is WINTHER. Is that right?
Exactly.
Yes, very exciting. And you know what you were saying a moment ago about how statistics show that when just used as a standalone, the tumor DNA testing turns up about 25% of the time or so it finds a match.
Yeah.
With Alex's approach that I was describing with the extra research, we were able to bump that up to 80+%.
Yeah, exactly. It depends. Yeah, it depends on the method, on the study, and
sure.
And of course, when patients are coming to place like CTOM, where you have some real team dedicated to look in details for patient, the outcome is better. But when you are treated in a huge cancer center place, where you're just on the floor of patients, and they're usually oncologists, they're just using standard of care guidelines. Yes. And when we have reached 3 or 4 treatment and there's no more options, usually they just tell you should go on how to say, palliative care. A personal story I keep on telling is maybe the reason I've created OmiCure is, of course, like many people, I've lost my parents to cancer years ago. And I remember for my father, after the third treatment, he went to see his oncologist team, and the oncologist team telling him, okay, Mr. Turcat, now we got 3 other treatment to offer. We don't know which one to offer. So we've put 3 small pieces of paper on the desk. Please pick one. And currently it's not so far from reality, still from reality today, because when oncologists are going, when patients are going out of standard of care, there are no more guidelines. And so oncologists need actionable and personalized data to be able to choose the next option.
Yeah.
And if they don't have any personal data, they just can launch a dice and choose something.
And that's what we find often, is that in Canada specifically, it's just this really weird bottleneck right now, where tests like yours exist that can help oncologists identify treatment options. I'm aghast to hear that story, frankly, about your dad. I can't imagine what that was like. It's like play the shell game with your life here,
Yeah.
What is that? But that is just so common. In Canada, that wouldn't even happen. There would be the standard options to chemo, radiation, maybe as a third line, hope we throw some immunotherapy at someone or something. But
exactly.
But the oncologists here would not be willing to even give those other options without data like yours. Because, I believe there's an element of Hippocratic oath and good intention there, in the sense of doing no harm. I'm going to give them that. And at the same time, what we're here to talk about today and make sure that people who are cancer patients or advocates know is that there are tests out there, especially OmiCure, this RNA and artificial intelligence test, that can, with great confidence, identify treatment options for you that are far beyond standard chemotherapy and radiation. So if you've been told that you don't have any options and your doctor hasn't made sure that you have one of these tests, then your doctor doesn't have enough information to tell you there are no options. It's that simple. And I'm sure they mean well, but this is your life and we don't want you to play the shell game.
But Michelle, unfortunately, most of oncologists doesn't even have the molecular knowledge. They of course, they know what is DNA, what is the RNA, but they don't know how it really works in the cells. They are mostly taught to apply standard line guidelines, and they're not allowed. Usually, they're not allowed to go out from that.
No, this is true. Around the world, that is fairly typical. We're both really celebrating this last decade in terms of what is starting to evolve in the way of cancer care, which is more technology and more treatments specific to each patient's genetics and the molecular profile. But as you say, most frontline oncologists are medical oncologists, have no training in this area. Their role is to administer the treatments that their administration tells them are best, and to make sure that your side effects are manageable, and keep an eye on things.
Exactly.
Yeah, so there are some countries that are starting to have, as part of their healthcare system, research-based oncologists. At least that's my understanding. Is that your understanding as well? Is there starting to be more appreciation for the need for research oncologists or clinical oncologists, as well as the frontline medical oncologists?
Most medical oncologists, they don't have time, in fact, to deal about that. No. But indeed, and we are working with many huge cancer centers, mostly in Europe, where they know that DNA is not enough, and they know they should go on RNA, and they're trying to include our method and our test in their new clinical trial in order to see how to combine DNA and RNA. But this is why we've decided with my co-founder to offer this kind of test not only to oncologists but directly to patients, because I think as Tom say, knowledge is power, and patients need to ask this test to get the data, and to go and tell the oncologist and medical team to challenge them in a positive way to say, okay, I understand I am out of guidelines, but look, with this data, we might be able to choose the next option.
Yes.
Really, and because you going back and in maybe 2, 3, maybe 5 years, RNA expression will be used in all standard of care, but this takes times because I don't know, the systems in order to protect the patients and before to apply it to all patients, they need a lot of tests, they need a lot of measurement, and it will take maybe 2 years, 5 years, maybe more.
Oh, and depending, of course, on the system and whether, patients are encouraged to take action for themselves, or like in Canada, our public healthcare system definitely has its upside, but there are lots of barriers, and it's commonly there's kind of an energy of frowning that seems to happen when cancer patients in Canada start to look outside the public healthcare system for options. And predominantly that's because until recently there weren't any good viable options, and so patients were looking more to unproven or things that could potentially be harmful. So it's natural for oncologists to scoff a little, or at least to have some uncertainty. But a test like yours, it provides that clarity, it provides that certainty, and it provides the information, not just the names of the genes, not just the names of the treatments, but information about how to read more about those studies, and anything if an oncologist did want to take a few minutes to look into things for a patient.
Exactly. In fact, I didn't mention it earlier, but our AI platform is what we call an explainable AI platform. This means that it's not like these black boxes just giving a result and you don't know why. For each drugs, where there is an explanation saying, okay, this drug has been chosen because there is this gene and these genes, and this gene has this level of dysregulation, and then there is a link to some publication explaining in which case, in which trial, it has been demonstrated that this drug were increasing or decreasing the expression of these genes. It's really so. Oncologists, if they want, they can deep dive into the information and understand why this drug might help the patient.
Yeah, as you say, that many oncologists don't necessarily have that molecular background, or frankly, the time. And recent studies in North America show that oncologists have about 15 to 18 minutes to spend per patient. That's all they've got. So they're not there. And again, they're not really encouraged to think outside the box or explore, novel concepts. It's, it's considered, experimental, which of course we don't want to do. But this is not considered experimental. What your test provides, you're providing links to vetted treatment options.
Exactly. In fact, we are a bibliographical tool. We don't make assumption. We just linking the profile, the RNA profile of the tumor to existing knowledge.
Yes. So there's no bias.
I mean, anybody, if any oncologist would be able to spare 200, 300 hours looking for any patient, he might be able to reach the same conclusion.
Yes.
The main issue, he has not the human capacity to do it.
No, this is right. Yes. So this is why we're talking, is because it's important that people understand that with the data that a test like yours can provide, their oncologist now has the information they need and can with confidence explore other treatment options for you. So,
exactly.
I'm sure that I'm sure I don't know about a daily thought, but I'm sure it's a regular thought that if only this had been around for my dad.
I told you, it's really the main reason I'm launched because all medical and the scientific and the data science and I am an engineer, but I'm more a marketing guy or e-commerce guy, and by when I met my co-founder and he tell me about this solution and struggling to introduce it into healthcare system, I told him, yeah, but we need to provide it to the patient community, because if my parents, I lost my father, my mother, my mother-in-law, you know, so I've been there. I've been there struggling to help them to understand in forums, to, you know, like everybody patient and everybody caregiver do, you know, just trying to find information.
Yes, exactly. So I think that personal experience and that drive that lived experience brings is a very critical element, and exactly what you're saying, because you know, it's kind of the same thing that got us going here at CTOM was our own, you know, my experience of my uncle getting a diagnosis of cancer, and just being in that window before these things were more recognized and accessible. And just the struggle that we had to try to get his oncologist to explore any new options. You know, really, that's a prime motivator. But I think it's taken us both in the same path, which is go directly to the people who need it right now. Get the information in the hands of the patients and their families and their advocates, because then they can, with our support, start to advocate for themselves with their doctors. If we wait for the establishment to pick up the ball and run with it, as you say, and I think that's a very liberal estimate to you know, to suggest it's going to be 5-ish years or so before I think that it should be that fast, but probably a little bit longer. But as long as oncologists are receptive to the data when it's presented to them, that's the thing that matters most. And that's what we see here, is that when we present your report and the information it contains, and you know, Alex does his extra deep dive into other possible treatments, oncologists, like 98% of the time, an oncologist who has previously said, no, sorry, we have no options for you, no, there's you know, palliative chemo, or this is the only option for your type of cancer, 98% of the time they are writing a prescription upon reading that information for one of those treatments that will be more targeted for their cancer. So it's exciting times, and there's every reason for people to gather this information and make sure their oncologist has it, but their doctor's not going to initiate this process right now, is where we're at.
They don't have time. And as you mentioned, the idea is to give data and information to the patient, so it will give him the power of challenge, and the challenge in a positive way, that the medical team say, okay, I know there is more option, and look at this data, look at this information, look at.
Yes. Yeah. Tell me, look me in the eye and tell me why, when this treatment is available in this country through our healthcare system, you're not giving it to me. And most oncologists, they're going to say, okay, yeah, you make it.
And you know, a lot of people ask me, but you're not afraid but oncologists won't like you and are afraid of you. And in fact, no, because oncologists, they don't have the time, as you mentioned, and they're happy to say, oh yes, this is interesting. Oh yes, I didn't think about it. Yeah. You know, most of course there are some oncologists that don't like it, but you know, some,
well, that's just a lack of knowledge there, and they'll either retire or get on board, because those are the only, like, reality is reality. This stuff is critical data, and it's saving lives. So, you know, people, they will wrap their head around it for sure. I find, you know, in my conversations with oncologists who have been, we'll say, reluctant to support this kind of thing initially, once the data is in their hands, the tune changes. And again, that's why I say, I think it's more this concept of do no harm. They've just seen so many people spend so much money on things that had no merit. And because they don't necessarily understand this test or the value that it brings, they kind of assume, don't waste your money.
Probably. Mostly they don't have time. They're dealing with, as you mentioned, they're dealing with so many patients, and they have so many patients to deal with, and so they're just applying the standard of care guidelines. And when you're out, unfortunately, they don't have time to take care of you.
Yes, exactly. So that's where you and us come in, right? That's where
Exactly.
our team here with your test data and then you know, our research and advocacy, so that doctors don't have to take any extra time in order to provide cancer patients with better
Exactly.
options. Yeah. So tell me a little bit about where are you guys going? I mean, this is so new. I certainly don't want to in any way imply that this isn't excellent or that new things have to come. And this world is constantly evolving. There's new information about cancer treatment and new science. There's 98,000 clinical trials for cancer alone in the world right now.
Yeah, this is
It's exciting, massive amounts of data. So you must be furiously updating your AI system all the time, for starters.
is it exactly? It's a big challenge, but we're dealing with it. In fact, you know, as mentioned, our vision is to provide the most personalized data about the patient to the medical team. So we've started by RNA because this is the next step after DNA, and currently we are looking at cancer drugs, you know, in existing approved or in clinical trials. And we are working currently to enlarge this list of components with a nutriment and with I mean normal drugs, so what we call the repurposed drug, and also on the data patient point of view, we would probably and working in providing or adding imaging data and microbiota data also, in order you really to give the medical team the most comprehensive and the most precise uh, data about the patient in order to be able to select the best option.
Yeah. Wow. So let me just recap what you just said. So you're also looking at adding, you said repurposed drugs. In Canada, we also refer to those as off-label, or things
Yeah.
that were designed for other purposes but have been found to have benefit. So that's exciting to add that. And you said something about imaging.
Yeah. But there's a lot of talk and information about imaging and AI and diagnostic. So if we are able to combine the information from the molecular profile and the imaging profile of the tumor in order to be able to select some more or to sharpen the options,
Mhm.
that's something we're working on. You know, our sister company is working on imaging and AI also in oncology with some major cancer center in Europe. So it's something where where the research and development team is working in all these different directions and trying to gather the information to have the more comprehensive test.
As much information as possible. That's exciting.
Yeah.
And you mentioned food. Tell me a little bit
Yeah.
about what, just touch on for a moment, if you would, before we wrap up, about what you're envisioning being able to do around the nutrient side of things.
In fact, currently for OmiCure, we are looking at which drug may correct the dysregulated gene, the overexpressed. And in fact, some nutriments have some abilities also to increase the expression of some genes and to decrease the expression of some other genes. And there is some scientific knowledge about that. It's not just about a blog saying, okay, I know that tomatoes do that, and I know that cranberry is an antioxidant or this, but of course it's true. But there's some scientific knowledge, so we are gathering this scientific knowledge and using and put it in our knowledge base, and so we are able to provide a report saying, okay, with your cancer, please eat more of this food, please eat less on this food, and this is linked on this publication, on this scientific publication. So it's just not, we're getting out of the just the blog area of this is better, but you don't know which food is specifically better for you or for
That's right.
some other patient.
Yes.
So this is really the same idea, but something where you can you don't need the oncologist, you can adapt and adapt your own diet based on this, to try to help your body cure your cancer. It's not enough on itself, of course, to cure the cancer, but it will help the global health of the patient. There's the drug, there's the what you eat, there's your mental health also. Everything is helping.
Yes, absolutely. And, you know, Alex designed a nutraceutical diet for cancer a number of years ago, maybe 8 years ago plus now,
Mm.
based on some of this data that you're speaking about, the clinical trials and studies that were done to show how certain foods directly influence certain cancer
Yeah,
pathways or certain genes. Um, and one of the things that we hear time and time again from our clients is how reassuring it was, how empowering it was for them to be able to have this piece of data about something
yeah,
they could do. They didn't need their doctor to do it, that, you know, it was something that they actively could do that gave them a sense that they were helping to beat their cancer. And it is powerful how
exactly,
these foods affect things.
exactly,
So
exactly.
that's exciting that you're adding that
Yeah, yeah,
new element to your data.
it's coming very soon, and I hope we're already discussing with Alex and designing some specification with him about omic food, and so very soon we both would be able to provide it to some patients.
Excellent. So needed. So I'll definitely have another chat with you like this to talk more about that when
Sure.
that's ready to go, because I think lots of people would be very interested in that option for sure. Okay, I think I've covered everything. Let's see here. You mentioned, and I just want to recap this for people who are watching from home. You can order the OmiCure test. You do not.
Yeah,
Your
definitely.
doctor does not need to be involved. Although, again, you know what Tom and I are both saying is that in our experience, we see that doctors are highly respectful of this data and willing to explore the options that it provides. But you can gather this information on your own. Certainly, we're here to assist with this, and Tom's team as well. It takes about a month from the time the test is initiated, meaning sample arrives at OmiCure. Give or take 3 weeks to about a month for the results.
Yeah, usually we need a few days to collect the sample, but then what takes the longest part is the RNA sequencing. It's between 2 and 3 weeks, and then we need a few days to compute the data and to generate the analysis and to double check and you know run the quality control checking.
Sure. So safe to suggest that it might be about 4 weeks from the time you initiate the process to the time you have the test data in your hands.
Yeah.
You know, not a long period of time. It might feel excruciating while you're waiting, but the quality of information you're going to have and the treatment options that you wind up with that are so much more targeted for your cancer are so beneficial. So, Tom, people can reach out to you directly if they want more information, I assume. The website for OmiCure is omicure.com, nice and simple. You can track Tom down and ask him any questions yourself. Is there anyone else or anywhere else you'd like to send people if they want more information about you?
Of course, as we are teaming up with you very well since almost 1 year to now,
Yes,
I think.
Yes.
So we are making a very good complementary team.
Yes.
For most I think currently all patients from Canada we're working with you on
Yeah,
So
we're the only personalized cancer service in our country right now. Yeah, I know. This is really, but again, nature of maybe public healthcare system. But yeah, so I know Alex is extremely grateful to have your test and the data that it provides for his work and the options that he's then able to help.
And very often we have in deep discussion about some special case with a difficult case. We are able to, and when sometimes he needs some additional data or additional research, he asks us to deep dive into specific gene or specific. We are very happy to do it, you know, because
Thank you.
You know, we're all here for the same purpose, is to help patients.
Yes, as you say, knowledge is power. The more information that we can provide cancer patients and their oncologists, the better their outcome will be. So it's exciting for sure. Tom, thank you so much for taking this time to meet with me today.
Thank you for having me.
I'm very grateful for that. And I will meet with you again to talk more about the OmiFood test.
Yeah, OmiCure's, yeah.
Yeah, when that's ready to go. For those of you watching at home, I hope you do visit the OmiCure website, omicure.com. Reach out to Tom if you have any questions, and we can certainly help you with the coordination and ordering of your test if you'd like one. But most importantly, I hope what you got from today is that there's an option out there for you to be able to find information about treatment options that go well above and beyond standard chemotherapy and radiation. And if you haven't explored this option yet, I urge you to do so. Thanks very much.
Exactly. Thank you very much for having me, Michelle. Bye-bye.
You're welcome.